everyone. Happy evening, a very good evening. I hope and I believe you all are doing well. A quick nod whether the audio visual is all good. Just a minute, I'm not able to see the live chat. Yes, okay, now I can see it. So, thank you so much, everyone, for that quick nod. And first, tell me how your day has been with Orthopedics, the 35-day revision timetable that we are following. I've shared it right in the previous video, the 35 days. I hope you are on it, everyone. So, how much of orthopedics have you completed? 60%, 45%. Am I audible and visible? I think it went off. Okay, never mind. So, the day is yet to get over, and guys, pace up, still go very fast and finish whatever, you can in the limited time that you have. So, in this orthopedics binge revision, basically, there are many things that we are going to revise and at a very, very fast speed because this is like the binge revision that we are going to do. Okay. So, first one, tell me about your the fracture classification, right? Augustelos Anderson classification. In which fracture do you have? In which fracture do you have that the bone coverage is absent? Absent bone coverage. That means you see the soft tissues. And which one do you have vascular injury? Right? What is the trick to remember that? Remember that the bone coverage is absent. It is your bone coverage absent. It is your type 3B. Remember the type 3 fracture is the one which is your basically comminuted fracture. So it is B where the bone is absent. Vascular injury basically means your circulatory injury. So remember it is C and that is your 3C basically where you have the circulation is gone. So look at this one. Okay, so your complex or comminuted fracture starts from 3. In your 3B, there is no soft tissue coverage. The bone is gone and it requires reconstructive procedure. Vascular injury, if I am hiding this, okay, vascular injury is basically seen in your type 3C. This is the most important that I want you to remember. 3B is bone gone and C is your circulation. That means a vascular injury is there. Okay, now coming to the list of your osteochondritis. So many of you had been asking for it, the tricks to remember various osteochondritis. What is the osteochondritis of capitulum of humerus? It is the Penner's disease. Okay, it is Penner's disease. So remember that capitulum is your pen cap. So you have a pen and you have a cap of the pen. Remember Penner's disease is the pen and it is your cap. So capitulum is Penner's. Lunate is skin box. Remember, it's not collars. How do you remember this? Alphabetically, when you say, so you have G, H, I, J, K, and you have L. So after K comes L. So skin box is lunate. Remember, it's not collars, which is lunate. Why? Because collars is rhyming with navicular. Okay, collars is rhyming with navicular. So for the navicular, it is collars. For lunate, it is skin box. Femoral head is your Perthes disease. So remember Perthes, PTH, that is basically your proximal thigh. Okay, that is proximal thigh, that is Perthes. Proximal thigh is your femur head. Osteochondritis dissecans is basically your femoral condyle. Osteochondritis dissecans is seen in the knee. Remember, it is your condyle ka is COD, cash on delivery, condyle. Which condyle? The medial femoral condyle basically, and the lateral part. I'll show you the image also of osteochondritis dissecans. Okay. So this is what is osteochondritis dissecans. This is the tibia. You have the medial condyle, uska lateral part. Okay, that is your osteochondritis dissecans. So remember, lateral part of the medial femoral condyle. Then you have tibial tubercle, tibial tuberosity, TT is your TT, Osgood-Schlatter disease. Lower part of the patella, that is your Sinding-Larsen-Johnson disease. You can remember this as patella sliding down. Okay, so patella is sliding down, like that you can remember. So Sinding is sliding and down is your lower part of patella. Calcaneal tuberosity is your Sever's disease. Okay. So calcaneal, इसमें जो है ना doctor happiness, not all stagings, only the ones where the questions are expected. That is what you should remember. Okay. Then you have the next one, that is your calcaneal tuberosity. Okay. Calcaneal tuberosity is your Sever's disease. Call for save, right? We call for save, call for help, call for save. So this is your calcaneum is your Sever's. Okay, calcaneal is your Sever's, navicular is Kohler. Second metatarsal head, that is your Freiberg's disease. No mnemonic for that. Fifth is your Iceland or Island disease. Remember, high five. Okay, that is what we say, high five. High five is your I5. So that is fifth metatarsal. That is Island disease. Ring epiphysis of the vertebra. Okay, the ring epiphysis of the vertebra, that is Schurman's disease. So remember that only sure man. Okay, in Hindi, sure man. Sure matlab a brave man who is the only one who will enter into the ring. Okay, the boxing ring. Someone who's courageous, someone who is sure will only enter into the ring. So ring epiphysis is your sure man. So quick revision, cap is Penner's, lunate is Kinbox, femoral head Perthes. Then you have condyle, osteochondritis dissecans. It's the medial condyle, lateral part. Tibial tuberosity, Osgood-Schlatter. Lower patella, sliding down, Sinding-Larsen. Call for save, calcaneum is Sever's. Navicular is Kohler. Second is your Freiberg's. This is second head. And this is fifth metatarsal base. High five, and ring is your Schurman's. Okay, ring is your Schurman's. All right. So this is about your great EF. So February is the second month. So you can remember Freiberg's. That is basically your February. That is second. That's a good mnemonic coming that way. Thank you so much. So that completes the list. All right. So this is done. The last three. Second, we just now said February, Freiberg's. 5 is high five. That is Island, I5, high five. Ring, into the ring, only the sure man will enter into the boxing ring. Sure man is a courageous man basically. So sure man's is your ring epiphysis of the vertebra. Okay. So done with osteochondritis. The list which is there, look at the images. So this is the patella, lower part sliding the lower down, Sinding-Larsen-Johansson. Your tibial tuberosity, TT, that is your Osgood-Schlatter. So if you get a radiograph like this, patella lower end is where you are seeing that outgrowth irregularity. This is your Sinding-Larsen-Johansson disease. Okay. Look at these images. What will be this? This is the calcaneum bone, the heel bone, calcaneum, call for save. That is your calcaneum, Sever's disease. This is your tibial tuberosity irregularity, Osgood-Schlatter. Second metatarsal head, if it is shown, February 2nd, that is your Freiberg's disease. Okay. So done with this, going to the next one. So the next topic that we are seeing now is your test. So for everyone here, I have shared the PDF of this session already on the Telegram group. Dr. Nikita's Radsynapse. You can get the PDF, and if you want, you can make the notes also as we are discussing. Okay. Identify the test A and identify the test B. Okay, the test A and the test B. What is happening in the test A? The final result of the test A is that the femur is getting dislocated, right? In the second, you can see the femur is getting relocated. Okay, it is getting relocated. So the mnemonic is one test for, these are basically the test for DDH. So you have Barlow's and you have Ottolani's. Okay, Barlow's and Ottolani's. The trick is Barlow's is like Bahar low. Okay, Bahar low. That means get the femur head out. That means it is dislocated. Okay, it is dislocated. And remember, when it is dislocated, it is your bad. Okay, it is your bad. That means Barlow's is basically the adduction. Okay, Barlow's is the adduction. Ottolani, matlab andar lavni. Read it like that. Ottolani is like andar lavni. That means it is relocating. If Barlow's is adduction, Ottolani's is abduction. So if you see the splints used in DDH, your Von Rosen, the Craig splint, they are put in abduction so that the femur is in its position, right? You will see the splint also which is kept in the abducted position. Okay, so abduction takes it back. Okay, abduction takes it back. So this one where you see it is getting your dislocated, that is your Barlow's, and Barlow's is adduction. Okay, where it is getting relocated, under Lavni, Ottolani, abduction. Okay, that's the abduction. So Barlow's and Ottolani's. These are the tests that are again mentioned here, the same thing for your reference. Next one, what is this test that is being shown here? The patient is standing on one leg and we are looking at the other side of the pelvis, whether it's going up or it's drooping down. What is this test? This is the Trendelenburg's, right? This is your Trendelenburg's. Basically, today itself we have posted a mnemonic on this, right? Trendelenburg's, which is basically done for the abductors of the hip. Abductors of the hip, the gluteus medius and minimus. Gluteus maximus, the piche wala main muscle, that is the extensor. What are these muscles supplied by? They are supplied by superior gluteal nerve, right? They are supplied by superior gluteal nerve. So in this case, if I ask you that when the patient is standing on this leg, the opposite pelvis is dropping down, what palsy are you suspecting here? Is it the right side or is it the left side? Is it the right side or the left side? So remember, drop, it is the opposite side which drops, opposite to the injury. The patient stands on the abnormal side. The patient stands on the abnormal side. So this is the left leg here on which the patient is standing. So stands on the abnormal, that means the left side is abnormal. It is the left side which is palsy. The opposite side, that is the right side, is dropping down. This is going to be your left superior gluteal nerve palsy. Is this clear with everyone? So abnormal pe the patient stands, opposite drops, drops, opposite stands on the abnormal side. Okay. So this is your Trendelenburg's. Okay, what is this first test here? What is this test here? You can see that the thigh, it is basically we are flexing. We are neutralizing the lumbar lordosis. This is basically your Thomas test. Remember, Thomas, again, basically related to the thigh, that is the hip. It is done for fixed flexion deformity of the hip. Okay, it is done for fixed flexion deformity of the hip. Second one, what is this? A very, very trendy test like you can see here. So the female is lying on the one side and then you can see the test we are doing abduction. What is this test? The second one. This is the Ober's test. Ober's, remember OB is done for AB. The abduction wala, that is your iliotibial band contracture. The contracture of the ITB, it is done for that. Okay, that's your Ober's. The ITB is located on the lateral aspect. So the patient is lying on the lateral aspect. And this is your Trendelenburg's. Okay, this is your Trendelenburg's. What is the palsy here? The right side. Because the patient is standing on the right side. Opposite side, the left side is dropping. So it is the right side which is palsy. Okay, the right side is palsy. Tell me what test is this and for which muscle we do this test? This position that we are giving to the patient, what is this for? Absolutely right, Medwin. Yes, this is basically done for subscapularis. Okay, this is done for subscapularis. So we ask the patient to take this position and try to lift off. Okay, this is called as lift off test. Okay, this is the lift off test or the Gerber's test. Okay, that is your Gerber's test or the lift off test that is done for subscapularis. Okay, this is done for subscapularis, lift off or Gerber's. Okay, so lift off, Gerber's, subscapularis. What are we doing here? So in this test, basically you can see at this position and then it is pressed down, the shoulder is pressed down. This is for apprehension test basically. The anterior shoulder instability basically for that. This is the test done for to look for the instability of the shoulder anterior dislocation. Okay. What is this for? We are trying to tap here. What nerve passes here related to what is this? The medial epicondyle. What nerve passes here? This is basically your cubital tunnel, right? This is the cubital tunnel. So we are tapping on the nerve. This is called as the Tinel sign and it is basically for the ulnar nerve. Cubital tunnel, medially ulnar nerve. Carpal tunnel is your Carpal tunnel is for the median nerve. Tarsal tunnel is which nerve compressed in the tarsal tunnel? Is it deep peroneal nerve? Is it your tibial nerve? In tarsal tunnel, it is the tibial nerve. Okay, that's the tibial nerve. All right, so this is Tinel's, basically ulnar nerve, cubital tunnel. Next one, what is this test being done for? This one, here the forearm is in the pronation. So basically it's the extensor aspect of the forearm. So remember your common extensor origin, that is your lateral epicondyle basically. So for the lateral epicondyle origin, the lateral epicondylitis, that the inflammation there, that is the tennis elbow. Okay, this is for the tennis elbow. That is the Cozen test. Okay, that is your Cozen test. So Cozen test, tennis elbow, that is lateral. Okay, that is lateral. Okay, so this is your Cozen. Next one, when you do the test in this position, that's your supination. So that is your flexor compartment. Flexor is your medial. We are looking for the medial epicondylitis, which is called as golfer's elbow. So if you are given an image, identify whether this is for golfers or your tennis. Tennis is here, extensor, prone position, pronation, and this would be your supination for the golfers. Okay. So this one is going to be for tennis or golfers. This is your pronation. So this is for the tennis elbow. That is the Cozen's test. Okay, this is the Cozen's test. Next one. What test are we doing here? Where are we doing this basically? Where are we feeling the tension here? Yes, the reverse Cozen's test basically. Absolutely right, golfers. This is where you can see the tension in the anatomical snuff box. Yesterday we read about the boundaries. So basically your tenosynovitis here, which is called as de Coubert's. This is called as Finkelstein test. Okay, this is your Finkelstein test, basically which is done for de Coubert's tenosynovitis. Which tendons are affected? So basically the lateral border here of the anatomical snuff box, which we saw yesterday, the two muscles which are there, the abductor pollicis longus and the extensor pollicis brevis. Remember the muscle insertion we saw yesterday? APL on the metacarpal, EPB on the proximal phalanx, and then you will have the EPL going on the distal phalanx. Okay, the EPL going on the distal. So the lateral one, that is your APL and EPB. Okay, APL and EPB. So Finkelstein test, de Coubert's. Okay, that is your de Coubert's. Okay, look at this test. What test is this? This one. This is the phalanx test, right? Basically for the carpal tunnel median nerve, this is the phalanx test. Phalanx test for the carpal tunnel, that is the median nerve compression. Very, very important. This is the phalanx. How will you remember this? Phalanx is like fallen. Phalanx is like fallen. So you have the fallen hand. The hand are falling down like this. So remember, that is your phalanx. That is your fallen. This is phalanx, not the reverse phalanx. Okay. Next, coming to the test of the knee. What is this? Is it your Latchman's? Is it anterior drawer, posterior drawer, McMurray's? What test is this? Yes, reverse phalanx will be the prayer sign basically. Yeah, you can see the position here. Right, you can see the position and the pull is being done anteriorly, right? The pull is anterior. This is anterior drawer test. Anterior drawer, anterior is for ACL. Okay, anterior is for ACL. So this is the anterior drawer test. Similarly, the next one that you have, same position, but now you see it is being pushed posteriorly. Okay, the force is given posteriorly. That is the posterior drawer test. Okay, that is your posterior drawer test. Next one, this one which you see here. What will be this test? So when you see one hand on the thigh, one hand on the leg, so that is like latching the two together. That is your Latchman's test. Okay, that one is going to be your Latchman's test. Here the flexion is comparatively less. So remember that in Latchman's, one hand is above, one hand is below. In your drawer test, both are on your tibia, basically the leg, okay, not on the thigh. So Latchman is latching one on the thigh and one on the leg. That is your Latchman's test. This one, right, where you see that the foot is being held and then you see the rotation movement. This is basically for the meniscus. Meniscus is your McMurray's. Okay, meniscus is your McMurray's, and that is how you would see the McMurray's for the meniscus. Okay. The test for the knee, which you see that the patient is lying in the prone position and then we are trying to do the grinding. This is in the prone position, the test in the prone position. That is your Apley's test, the grinding, the Apley's grinding, again done for the meniscus. Okay, again it is done for the meniscus. That is your Apley's grinding in the prone position. For a quick revision here, Latchman, we said one hand is above, one hand is below, the flexion is less. Latchman is also for, remember Latchman, LAC, ACL, Latchman's test is for ACL injury. Anterior drawer, the pull will be in the front. Posterior drawer, it will be pulled behind. Angle is 90 degrees. In the prone position, it is your Apley's for the meniscus. And this one is your McMurray's again for the meniscus. And then you have the lateral pivot shift, which is again for ACL. Okay, it is again for ACL. Okay, tell me what test is this? What test is this one? So here you can see the position of the patient basically like this, the empty can test, right? The thumb is going down, emptying it. This is the empty can test, which is done for empty can test. This is done for supraspinatus. Okay, this is done for supraspinatus, the empty can test. Okay, that's your empty can test. This is not AdSense. In AdSense, you will see that the patient turns the head to one side. Okay, this is the empty can test. That is your supraspinatus. What is this test? Fixed flexion deformity of hip. This is your Thomas test, right? This is the Thomas test. Okay, what test is this? This is an interesting test here. You can see both the hands going up like a booth. That is your booth wala position. You know, when you're trying to scare someone, booth wala position. This is your ruse test. Booth wala is your ruse test, which is basically done for thoracic outlet obstruction. So remember, ruse is for twos. That is basically thoracic outlet obstruction syndrome. You have the ruse test, that is your for thoracic outlet obstruction. The other test that you have is your AIIMS test. The patient turns to one side and you have the right test. Okay, and you have the right test. Next one. What test is this? This, we are pressing the arteries and we are looking for the the adequacy of the circulation. Like before we are doing your fistula vagera, AV fistula, the adequacy of the circulation, that is your Allen's test. Okay, that is your Allen's test. Allen's test is basically to look for Allen, all is well. Okay, all is well, that means the circulation is adequate. This is your Allen's basically for circulation adequacy. So those were the important tests. Now coming to these tests, the nerve palsy wala test. Test number 1, 2 and 3. What are these tests? The first one is the pen test. Okay, the first one is the pen test. What is the pen test done for? Now a quick summary of your test for the nerve injury. Remember that the mnemonic is basically for the ulnar nerve palsy. Ulnar nerve is your musician's nerve. Ulnar, remember A, B, C, D and you have E and F. So ulnar, you will write it like A is ulnar. You have the book test, you have the card test. DE is for dorsal interosseous, you have the Igawa test and F is the froment. So remember all the A, B, C, D, E, F, that is for the ulnar, right? So you have the book test, froment sign, card test and you have the dorsal interosseous, the Igawa test. Okay, the Igawa test. So this one which you see here, the book wala, froment or book, that is for the ulnar nerve palsy. This one which is the card test. Okay, the card test is for the adduction, that is done by palmar interosseous. So palmar interosseous, card test. Dorsal interosseous, the abductors, the Igawa test. For the median nerve, it is all your PP, pointing index, the Pope benediction test and the pen test, right? You have your ape thumb deformity, that is also P. So remember all this, even the Oshner's clasp test, where the patient is, you ask the patient to clasp and you see the pointing index basically. Oshner's clasp is also for your median. So remember basically for median, alphabetically LMNOP, Oshner's clasp and all the P. The pen test, the pointing index, the Pope benediction, ape thumb, all of this is median. Okay, all of this is median. Winging of scapula, the long thoracic nerve, that is the nerve of Bell. Erb's palsy is your this position, the policeman tip deformity, that is the porter's tip. In Erb's palsy, where is the palsy? Basically your upper trunk. Remember Erb's, you write Erb's as URB, it is the upper trunk which is going in your Erb's palsy. Okay. Radial nerve causes the wrist drop. Remember Dr. Kuma, drop is seen with the radial nerve. And similarly foot drop is with the peroneal nerve palsy. Okay. So this was asked in your NEET PG 21 exam. This is the pen test which is done for the median nerve. Very, very important. Okay, very, very important. Okay. So these are the mnemonics that you need to remember. Ulnar, A, B, C, D, E, F. These are the tests for the ulnar. And median is your O and P. Oshner's clasp, pointing, pen test and the ape thumb, Pope benediction. Okay. All right. Going to next one, the important angles. What angle are we measuring here? What angle are we measuring here? This is the Bowler's angle. Okay, this is the Bowler's angle which increases or decreases in the calcaneal fracture. Right, the calcaneal fracture. It decreases in the calcaneal fracture. It is the Gissane's angle which increases. Remember Gissane's, IN increasing, Bowler's decreases. Okay. So I hope all of you remember the calcaneal fracture, also called as the lover's fracture. Right, the history, the story mnemonic of our Virat and Anushka. So Virat doing the bowling, that is bowler. घिस के बॉल करते हैं, राइट? पहले बॉल घिसते हैं फिर बॉलिंग करते हैं. So you have Gisane's angle. When he does the bowling, he takes a wicket. Anushka, the lover, is very excited and jumps from the pavilion, and she gets the calcaneal fracture. That is the ulnar fracture. That is the lover's fracture. Okay, that's the lover's fracture. Remember, bowlers, Gisane's calcaneal. That is your lover's fracture. Okay. The angle that we are measuring here, basically your alpha angle and beta angle, remember that is your A, B, C, D. Where do we use this alpha, beta? A, B, C, D, remember basically it is used in CDH or DDH. The developmental dysplasia, alpha, beta angle is used in CDH or DDH. For screening in neonate, we do ultrasound. Okay, we do ultrasound. So you have the alpha angle and you have the beta angle. At least remember the names. So quickly revising the various angles. Carrying angle, remember we carry with the upper limb, right? There's a pressure on the elbow. So basically it is for cubitus varus and valgus. Bowman's angle, Bowman's is like Bahubali. Again, your Bahubali, so like the biceps, right? So remember Bahubali is basically your elbow fractures. Cobb's angle, CO, it is for scoliosis, okay, which is for scoliosis. Next one, alpha angle, beta angle, that is your DDH, ABCD. Then you have Southwick angle, Southwick, that is your SC, slipped capital femoral epiphysis. Neck shaft, we know it is coxa vara. Q angle is your patellar alignment. Remember on the patella, basically there's coming your quadriceps. Remember the Q is for patella. Kite angle is for CTEV. Remember kite, that is KTEV. Okay, that is your KTEV or CTEV. That is your kite's angle. Mary's angle is pes cavus. Mary's is pes cavus. Bowlers and Gisane's, that is your calcaneum. Bowler decreases, Gisane's increases. Okay. So these are the various angles that you should remember. Southwick is your SCFE. Q is your patella. Kite is your KTEV, that is CTEV, and you have bowlers and Gisane's. Okay. So this is your bowler's angle that is being measured here basically, right? This is the bowler's angle that is being measured. And this one is where you see the Gisane's angle, which increases in the calcaneal fracture. So Gisane's would be like this, facing upwards, the angle, and behind is your bowler's angle basically. That decreases and Gisane's increases. Okay, these are the images for Gisane's and your bowlers. Okay. All right, tell me, what do you think? Which fracture is this? Which fracture is this? Is it Coley's? Is it Smith? Is it Barton's? Is it Hutchison's? Is it Bennett's? What is this? Very good. It's a Barton's fracture. Why Barton's? Because remember, Barton's is your intra-articular. Barton's is your intra-articular fracture of the radius, where you see that, okay, so in this image, you see that it is reaching till the articular surface. The carpal bones are also displaced. It is dorsal Barton or volar Barton. What is this? This you can see is going dorsally. There is this dorsal displacement. So this is your dorsal Barton. Coley's and Smith are extra-articular. Remember ABCD. Coley's is your dorsal angulation, dorsal displacement. Smith is your SUV, that is volar angulation. Okay, Smith is volar. All right. This is your classical asked in the exam. So frequently the dinner fork that you see the dorsal displacement. So this is Coley's. Okay, this is Coley's basically. Okay, elbow we have already seen. Lateral is your tennis elbow and medial is your, remember lateral is your tennis elbow and medial is your golfer's elbow. Okay. Student's elbow. What is the student's elbow basically? Right, the student, the elbow on the desk all the time and writing. The behind one, that is olecranon is present behind. That is your olecranon bursitis, student's elbow. For the knee, this we have seen already. Okay, for the knee, what is housemaid's knee and clergyman's knee, which is infra and which is pre-patellar, which is infrapatellar, which is pre-patellar. Yes, housemaids is your pre-patellar, clergyman's is your infrapatellar. Okay, so remember HP, write your HP ka laptop or uska ink, HP ink. That is housemaids is pre-patellar and infrapatellar is your clergy. Ink like your ink, write C rather than the ink. That is your ink. Infrapatellar is clergy. Pre-patellar is housemaids. Okay. Next one, we have seen this thoracic outlet. You have the roots, that is the booth, that is thoracic outlet, AdSense, and the right test. This is your roots test. Tennis elbow, this all we have seen. What fracture is this? What fracture is this here? Absolutely right. This is your Montegia fracture. This is not Galeazzi. This is Montegia. For Montegia and Galeazzi, remember Murga. That is the mnemonic. Murga. So Montegia is ulna. Radius is Galeazzi. Okay. So here you see the bone which is fractured. It is this bone, right? It is this bone which you can see is fractured. This is the head of the radius. This is the ulna, the olecranon, basically going up. This is ulna fracture. And in Montegia, it ends in A. A is your proximal alphabet. When you say A, B, C, D, it is proximal radioulnar joint. That is the radius head which is dislocated, right? It is the proximal which is dislocated. In Galeazzi, remember it is Z. Z is the distal alphabet. It is your distal radioulnar joint dislocation and it is your radius fracture. Okay, that's your radius fracture. Okay. Remember Murga and your Montegia and Galeazzi. Okay. All right. Identify these fractures quickly. What fracture? The named fractures here basically. What are these fractures that you are seeing here? So in the first one, that is your talus fracture. Okay, that's your talus fracture. This is the talus bone forming the ankle joint. So talus fracture, that is the aviator fracture. Okay, that is your talus, aviator. Then you have the calcaneal fracture here. This is the lover's fracture. This one, you can see a small avulsion fracture, the tibia, the lateral tibial plateau, basically. Why lateral? Because you can see the fibula. What is this fracture called as? What is this fracture called as? This is called as Sigond's fracture. Sigond fracture. Whenever there is Sigond fracture, we should do MRI to look for ACL injury. Right? What is your O'Donnell's triad? What is the O'Donnell's triad basically? The O'Donnell's triad, remember the mnemonic is MAM. That is, it is your medial meniscus, ACL, and medial collateral ligament injury. Okay, the three structures which are injured together. So that's your Sigons, ACL, O'Donnell triad. This is your both the malleoli going. Remember bimalleolar, that is the Potts fracture, bimalleolar. This one is your bumper fracture. You can see the fracture, the lateral tibial plateau fracture, that is the bumper's fracture. So look at this, basically what we saw. Bumper, it is your lateral condyle which is gone tibia ka. Then we saw Potts is bimalleolar. Potens is the third alphabet, it is trimalleolar. Then you have aviator which is neck of talus and the rest of them which are there. What is Tillock's fracture? An important one. What is your Tillock's fracture? Avulsion fracture, remember TI is TI, it is your tibia. It is your tibia ka fracture. So basically your ATFL, that is avulsed and that leads to the tibia ka fracture, that is your Tillock's. Pillon's fracture is your intra-articular fracture of tibia. Pillon's is like the mortar and pestle, it is going inside. That gives your intra-articular fracture of the distal tibia. Okay, that is your Pillon's fracture. All right. Look at this, the vertebral fracture here basically. The one which is horizontal and the one where it is the vertical compression. When there is vertical compression, the height is decreased. There is this burst which is happening. So this is the burst fracture. That is your vertical compression. When it is horizontal, the seat belt injury, giving your horizontal injury, that is your chance fracture. Remember, chance is horizontal, burst is your vertical. Okay, burst is your vertical. So these are the various fractures of the vertebra. Burst is vertical, chance is horizontal. What is clay shovelers? Remember clay shovelers. What is your clay shovelers? CL, that is your cervical spine, lower end, that is C6, C7 और उसके नीचे T1, उसका spinous process का fracture. Remember clay shoveler, cervical spine, lower end, it is the spinous process fracture. Dense is your odontoid. Hangman fracture is the pedicle. Both the pedicles of C2 are gone. That is your hangman's. Jefferson is 1. So that is your first cervical vertebra. That is your atlas. What is motorcyclist fracture? The base of the skull. Motorcycle is the base of the skull ka fracture. Whiplash is your hyperextension. Okay, that's your hyperextension. And then you have your undertaker's fracture, which is again your lower cervical spine with the disc disruption. Not very important. But remember your clay shovelers, hangmans, Jeffersons, motorcyclists, all of these are very, very important. So clay shovelers, cervical, lower, it is your spinous process. Okay, it's your spinous process. Tell me what classification is used for this fracture? What classification is used for this fracture? This is your humerus ka fracture, the proximal humerus, right? It is your humerus. Humerus is your needs classification for proximal humerus. Remember, needs is your Nikita's Radsynapse. It's a humerus platform full of mnemonics. And if you follow that, you will get a proximal rank, right? So to remember all of this, proximal rank, proximal humerus, Nikita's Radsynapse, that's your needs classification. Where do we use the Schatzker's classification? Schatzker's classification is used for Schatzker's is rhyming with your Osgood Schlatter. Remember the Osgood Schlatter? That was for tibia. So similarly here, this is for tibia. Okay, Schatzker's is for tibia. Iceberg, remember, imagine someone carrying the iceberg on the shoulder. Okay, on the shoulder, that is the glenoid. So this is basically for glenoid fracture. Gartland, I've given you the, the history, the story basically. Imagine like on your wedding day, the garland that you are putting into your spouse's neck, it is basically put here, right, over the elbow. That is your supracondylar humerus. So imagine yourself having the garland here above the elbow, supracondylar humerus fracture. Okay, that's your supracondylar humerus. So this is tibia plateau, intra-articular glenoid fossa, and this is supracondylar humerus. Okay, what are we seeing here? What are we seeing here? आप क्या पढ़ाओगे? हाँ? Yes. What are we seeing here? That is your gunstock deformity. That is a gunstock deformity. That is cubitus varus, which is seen with supracondylar humerus fracture. Okay, supracondylar humerus fracture. Okay. Yes. So that was Kyra there, and she's like, "मैं पढ़ाऊंगी students को." Absolutely. What is the most common vessel injury in supracondylar humerus fracture? That is your brachial artery, right? You have the brachial artery going there. So brachial, the nerve injury, anterior, that is your anterior interosseous nerve, and the most common complication is your malunion, and you get your cubitus varus deformity, right? The cubitus varus. All right, tell me what line are we seeing here and what is this used for? What is this line called as? So this is basically called as the cleans line. Okay, this is your cleans line, which is used for SCFE, the slit capital femoral epiphysis. The line should cross the femur, right? It should cross the proximal femur. If you see the head is medial to it, that's your slit capital femoral epiphysis. What angle did we say for this? The Southwick angle, right? SCFE, the cleans. If it is positive, it is called as Trethovan's sign, right? That's your Trethovan's sign. What is this line? The Shenton's line. Shenton's line. The imaginary circular line joining what cortex of the femur neck? Is it the medial cortex or the lateral cortex? It is the medial cortex of the femur neck, and through what it passes basically? So basically your Shenton's line is like this. It is passing through the medial cortex of the femur neck. This is your superior pubic, right? The superior pubic ramus, the lower border of that. Okay, so remember that is your Shenton's line. It goes like this. It should be continuous. And this is your obturator foramen. Okay, this one is your obturator foramen. Okay? So this should be continuous. If not, you suspect your fracture femur or the hip dislocation. That is your Shenton's line. What is Knelton's line now? What is the Knelton's line? What does it connect the two structures basically? So Knelton's line is your ischial tuberosity to the ASIS. Okay, these are the two lines, and you should see the greater trochanter of femur, which should not be above this line. If there is hip dislocation, it will go above that line. So Knelton's basically connects your ASIS to the ischial tuberosity. Okay. So this is your Knelton's line. Okay, this is the Knelton's line that we are seeing here. Next one. What is the first compartment and first symptom in compartments? Okay, so I think we'll have to complete this soon because my daughter seems to miss me. So that is now we'll have to do. Okay, test for flexion contracture. We have seen it's a Thomas test. The next thing, if there is avulsion fracture of the anterior inferior iliac spine, basically what muscle has contracted which has led to the anterior inferior iliac spine? That is your rectus femoris. So basically remember, if you get image like this, that could be your radiograph as well. So this is your ASIS. What attaches there is your sartorius and TFL. Your anterior inferior is rectus femoris. That is what the question was. Greater trochanter, very, very important. The hip rotators and the abductors, gluteus medius. Lesser trochanter is your iliopsoas insertion, very, very important. Ischial tuberosity is the hamstring muscles, and pubic ramus is your adductors and gracilis. So look at the radiograph. This is where you have the anterior superior iliac spine, anterior inferior iliac spine, sartorius and rectus femoris. Greater trochanter, very, very important, gluteus medius minimus. Lesser trochanter, iliopsoas. This is the ischial tuberosity, that is the hamstrings. And here you will have the adductors. Okay, here it would be adductors. Okay. Hello. What is crescent fracture? Crescent fracture is dislocation of the SI joint. Okay, if you are asked, what is the dislocation of? Shoulder joint, hip joint, elbow joint, SI joint. Remember, crescent is your SI joint. Okay, it's your SI joint with the fracture of the iliac blade. So, that is your dislocation of the SI joint basically. That is your crescent fracture. What is the Kocher-Langenbach approach which is used for? Structures of the acetabulum, approach to what structures? It is the posterior structures that we try to approach. Okay, so that is your Kocher Langenbach is your posterior structures of the acetabulum. Abduction contracture, we said it is evaluated by the Ober's test already. We have seen this test. Ober's, the lateral side, that is the abduction, that is Ober's. OB is AB. Where do you see the Hawkins sign? Thank you so much, Shubham. Yes, Pratima, some other time. Hawkins sign is seen in fracture of the talus. Is it a good sign or a bad sign? It's a good prognostic sign. So basically the lucency that we see below the talus, that indicates it's a good vascular supply. So the AVN is less likely. Remember Hawkins sign, talus fracture, aviator. Aviator is like a bird, and remember hawk, that's a bird. So Hawkins and aviator. Okay. Increased Bowler's angle is seen in fracture of calcaneum, true or false? It's a false statement. It is your reduced Bowler's angle. Okay. And what is this fracture here that we are seeing? The ATFL that is leading to the pull of the distal tibia. This is called as what fracture? We have already seen this. This is your Tilloch fracture. Remember Tilloch, that is your tibia lower end. Okay, tibia lower end, that is your Tilloch. Okay, that's your Tilloch. All right. Next one here, identify the sequestrum, the most important. The white dead bone that you see, that is the sequestrum. Involucrum is the new periosteal reaction, and the opening in the bone, that is the cloaca. Okay, that's the cloaca. So this one, the dead bone which you see, that is the sequestrum. Okay, that's the sequestrum. All right. Okay, so guys, we'll have to stop here. Okay, and I think Kyra is very, very eager to say hi to each one of you. Come. बोलो हाय सबको. हाय. कैसे बोलते हो? हेलो एवरीवन. हाय एवरीवन. हाँ. डॉक्टर निकिता. हाँ. पीछे. हाँ. पीछे. हाँ लिखो. ये. हाँ. Standing line, sleeping line. Standing line. Very good. Sleeping line. Yes. अभी और? Very good. So here it is Kyra now. So teaching us the back to basics, the standing and the sleeping line. चले? हो गया? बाय बोल दे सबको. बाय. बाय. गुड नाइट. इसमें स्टूडेंट आते हैं? हाँ, इसमें स्टूडेंट्स आते हैं. क्या स्टूडेंट्स नहीं दिखते हैं. नहीं दिखते हैं. चलो बाय बोल दो. गुड नाइट. गुड नाइट. Good night. All the best. All the best. कैसे? कैसे? All the best. Okay. So thank you so much, everyone. So yes, Dr. Nikita. Happy evening. Okay. So no worries. I think she can understand, but I need to look to her as well. So we'll stop here for today, and maybe we'll continue next time. Okay. So good night, everyone. Have a good sleep, and I'll see you again tomorrow. Till then, goodbye. Take care, and keep studying, keep revising, and keep winning. Thank you so much.